Welcome to the UT Health East Texas Virtual Education Series. Today's presentation topic is Asking for a Friend, What Every Man Needs to Know About Their Prostate, featuring Dr. Stephen Lomax, urologist at UT Health East Texas Urology in Tyler and Jacksonville.
Today we're going to be talking about prostate health and asking for a friend what every man needs to know about their prostate. So first off, I want to start off with what exactly is the prostate and answering that question. So the prostate is a reproductive gland that is in the male pelvis. It produces important enzymes and fluid that essentially provide the nutrients that sperm need to be able to survive in the female reproductive tract. Interestingly, the prostate and the seminal vesicles actually produce at least 70% of the volume in a male's ejaculate. And so that's what the prostate is. One way I like to talk to patients about what the prostate is and kind of the purpose of the prostate is it's sort of like a train station with different tracks that controls what's passing through. Because both the urine passes through that area and, like we said, the semen comes through. And so ultimately, it has to control only allowing one or the other to pass through the urethra. Now, not only what is the prostate, but where is the prostate? So in this diagram, you can see the blue area I just highlighted is exactly where the prostate is in the male pelvis. In front of the prostate is the pubic bone. Behind the prostate is the rectum. On top of the prostate is the bladder, and right below it is the urinary sphincter that controls your urinary stream. Now, what are some things that can affect the prostate? The benign prostatic hyperplasia, or AKA also known as enlarged prostate, is something that's super common that men will deal with. So I wanted to take some time to talk about that. When BPH, or that enlarged prostate, becomes large enough, that benign growth of the prostate can lead to urethral compression and outlet obstruction of the bladder. When that happens and there's obstruction of the bladder, it can also lead to symptoms that men often have as we age. It can also, in very severe cases, lead to urinary retention. How common is BPH? BPH is something that most men will deal with in their lifetime. Studies have been done that show as we age in the US, about 70% of men in their 60s will have some type of symptom from an enlarged prostate. 80% of men in their 70s. And so a lot of the times we say once you're in your 40s or 50s, it goes up by about 10% each decade that men will have those symptoms from an enlarged prostate. What are some of the signs and symptoms that would tell you that you actually do have an enlarged prostate? So we in urology call these lower urinary tract symptoms, and we separate them into two different categories, one being voiding symptoms and one being storage symptoms. Specifically within the voiding symptoms, we talk about having a weak stream, hesitancy in starting the stream, so taking a long time to do that, or having a stream that starts and stops while you urinate. On the other side of things, with storage symptoms, you have more things like frequency of urination that is increasing, or the urgency to get to the bathroom that can be very severe. When it gets really bad, you can actually have urge incontinence or leakage of urine on the way to the bathroom. And then of course, having nocturia, which stands for getting up at nighttime when you have to urinate in the middle of the night. So if you go to the doctor and you have these symptoms, what will they do? Well, they always start off with a medical history and a physical exam. That physical exam will include doing an exam of the prostate with a digital rectal exam. And often they'll do a urine test just to make sure that you don't have a bladder infection, because a bladder infection can often lead to those same symptoms. PSA is a blood test that we'll talk a little bit later in this presentation about, but is an important test for certain men, and especially if you have an enlarged prostate, and we want to make sure that we don't think anything with cancer is going on. In more complex cases, when you come to see me as a urologist, we often will do special tests, such as a cystoscopy, which is a small camera that we place inside the bladder to look around at the bladder and the prostate. Sometimes urodynamics, which is basically a test that we use to look at how well your bladder is functioning and how much pressure it produces. And then sometimes we also measure the volume of your prostate by doing an ultrasound through the rectal area. Just as an example of what a cystoscopy would look like, this is showing what we're seeing from a patient that has BPH. If you look at the right-hand side of the screen, there's a picture B that shows essentially what a normal prostate area would look like. That dark hole in the distance is the bladder, where the prostate is connected to the bladder. And it's a nice open channel. Where in picture A, you can see all that growth has gone on and is obstructing that view of the bladder. And so often that's what we will see when someone has a very enlarged prostate. What treatments are options for patients whenever they come in and they are diagnosed with an enlarged prostate? Well, medications is the first line of therapy for most men, and sometimes that's all they ever need. Alpha blockers are a specific type of medication that we will prescribe, either a primary care doctor or a urologist, and these types of medications help relax some of the muscle that's in the bladder and the prostate. That allows the urine to flow out easier and alleviates some of the obstruction that is there from the enlarged tissue. There's 3 medications that we use for that: tamsulosin, alfuzosin, and silodosin. Again, the main goal of this medication is to help restore the strength of the stream. 5-alpha reductase inhibitors are another option for patients. Finasteride and dutasteride are the 2 medications that we use in this class. And these essentially work on blocking the testosterone pathway specifically within the prostate. So it doesn't lower your overall testosterone level, but a downstream product of testosterone is decreased that helps shrink the prostate, because that DHT, or dihydrotestosterone, is one of the main drivers for BPH, or an enlarged prostate. And so when you take this medication, it helps shrink the prostate by about 20% in size. And because it takes time to shrink the prostate, it's usually a little bit slower onset to the benefit that you would have from this medication. Another important point is this is usually only helpful in men that have really enlarged prostates, because the 20% shrinkage of the prostate is much more significant in a larger prostate. So past medications, we get into more procedure and surgical options for the patient. There is a lot of these options, and so often at this point it's very important to be meeting with a urologist, a specialist like myself, who can offer multiple different outlet procedures to treat this enlarged prostate. The surgical treatment options, in brief, to overview these, are kind of classified into two different arms of treatment: minimally invasive and then endoscopic resection. Minimally invasive techniques include things that can be done in the office, and they're often good for prostates that are obstructive but not really, really big. They're usually recommended for prostates that are less than 80 milliliters in size, and they include 2 main procedures. One called the Resume, which is essentially a steam therapy that is used to inject into the prostate tissue that then allows it to shrink over time. And secondly, what's called the Urolift, which is a procedure where we basically use these tacking mechanisms to open up the tissue to alleviate that obstruction. When we go over to endoscopic resection, that is more of the gold standard, has been around for a lot longer, and there's been some new techniques that have come up as well. So the standard that you'll often hear about is something called the Roto-Rooter, or the TURP. And that is a standard good procedure that most urologists can offer. There's different versions of it. You'll hear bipolar TURP, monopolar TURP, green light TURP. Those are all specifics your specific surgeon can go over with you. Lastly, within the endoscopic resection class is something called the HOLEP, or the holmium laser enucleation of the prostate. That's something we offer here at UT Health, and it is a very good way to treat a very large prostate, especially for men that have a history of retention, where they can't pee. And it's sort of size independent. It allows us to still make no incisions on the body and do all the resection in an endoscopic fashion with scopes. So moving on to the next topic, prostate cancer screening. This is a super important topic for us to talk about as men because prostate cancer is something that almost never causes any symptoms. So the only way we find out about it is by screening patients. So a little bit about prostate cancer. 1 in 7 men will get prostate cancer in their lifetime. And that ultimately leads to about 30,000 deaths every year in the US. Higher grade disease prostate cancer is becoming more common, secondary to the PSA screening rates being a little lower over the last decade or so. And so it's a very important topic as a urologist specifically for me to make you aware of and ensure that both your friends and family are aware of. And again, like I mentioned before, the super important point here is that prostate cancer does not cause any symptoms. And so it's important to get screened. So what is the goal of screening? Well, the goal of screening for any type of cancer is to detect potentially lethal cancer at an early stage in order to have a cure for the patient and also to lower the burden of any treatment that has to be done. And so essentially just trying to intervene on the earlier side. The PSA is the test that we've been talking about. It's a blood test that we draw. It stands for prostate-specific antigen, and it's produced by prostate cells. When we see an elevation in the PSA, it's a good test. I tell patients all the time, but it's not perfect. It can be because there's prostate cancer there, but it also could be because you have an infection, inflammation, a recent instrumentation with a procedure or Foley catheter in the bladder. And so it's really important to be seeing a specialist when you're talking about the PSA being elevated above the normal level. So that brings me to my next point. What is normal for the PSA? Well, when you get your blood drawn as a man and you have a PSA, a normal level is considered below 4. Now, again, when we talk about the PSA, it can be normal for that PSA to be a little higher in certain situations like we spoke about before. So that's why it's just we need to be considerate of the PSA being elevated and be speaking with a specialist who can help determine if we need to be doing further workup for cancer. So who should be screened? When we look at some of the guidelines, there's different governing bodies that have come up with guidelines, but specifically some of the ones that we follow in urology are essentially all 40-year-olds and younger should not be getting screened for prostate cancer. As you get into the 40 to 54-year-olds, we don't recommend it for most patients. However, if you do have a family history of prostate cancer in a first-degree relative, that's a brother or a father, then we should probably start thinking hard about starting to screen you for prostate cancer with PSA on the earlier side of things. Really where the bread and butter is in the ages of 50 to 69. That's the age range where we definitely recommend it. Every man should get a PSA and know what their PSA when they're in that age range, as long as we believe their life expectancy is greater than 10 years. And most men nowadays, it would be. And so we recommend in that range getting a PSA screening with your primary care doctor, and if it's elevated, coming and seeing us. When you're greater than 70, it becomes more of a shared decision-making process between your physician and you as the patient. And the reason why is because it all goes back to what are the risks and benefits of potentially catching prostate cancer, which in most cases is slower growing, but can have effects on a patient still depending on their life expectancy and other medical comorbidities. So what do we do if a PSA is elevated? If you have a PSA that is high and you come to see us, then sometimes all we recommend is repeating the PSA at a shorter interval. Where typically we do it every year, we may say let's come back in 3 months or 6 months to see what your PSA is doing. If we're really concerned, or you have a family history or other things like that, depending on your specific situation, we may either recommend doing a prostate biopsy or doing an MRI of the prostate. The MRI is, as you can see on the screen, is shown here, and it shows the arrow pointing at an area on the MRI that looks concerning for cancer that we would recommend biopsying afterwards. So in summary, the prostate is a very important male organ that can lead to urinary problems and can harbor cancer without any symptoms. And so as we spoke about with an enlarged prostate or BPH, you can have medications, and often if medications aren't effective enough, then we have other surgical things that we can do for patients. And so it's important to come see us. For prostate cancer, it's most important for men aged 55 to 70. If there's one thing that you take away from this presentation, that's the important point I want to make. And it's really, really important, I can't emphasize this enough, that prostate cancer doesn't cause any symptoms. And so it's super important to get the screening done to be able to find it. Well, I appreciate your attention, and thank you so much. So one of the questions we got was, what does screening for prostate cancer involve? It's a great question. It essentially is very, very simple. It just requires a simple blood draw. The PSA can be checked almost at any lab, especially in the United States, and you don't have to fast for this to be done, and so it's just a blood draw. Another question that we got was, how can men lower the risk for prostate cancer? And that's a great question. We've all been looking into that as urologists for many decades, trying to figure out, is there any medication, is there any food, is there anything that we can do to really prevent prostate cancer? And unfortunately, even in the modern era of medicine, we haven't found anything that prevents prostate cancer from occurring, at least definitively. So staying healthy, being active, all of those things are super important for your overall health, especially if you were to get prostate cancer, to give you the best outcomes after being treated. But there's nothing that has been proven to prevent it. The last question that we received is, am I more likely to get prostate cancer if my dad had it? And that's absolutely true. So in that special population of patients, if you have a first-degree relative, which is either a father or a brother who has a history of prostate cancer, I would recommend that you talk to your primary care physician about getting screened for prostate cancer with a PSA, even as early as in your 50s. Thank you guys very much, and I appreciate it.
We hope you enjoyed the presentation today. For more information about scheduling an appointment with Dr. Lomax, call 903-262-3900. Our next virtual seminar will be announced soon. Follow us on Facebook to stay up to date on upcoming events and seminars. Thank you for joining.